Hi, and welcome to the Pro PA podcast. I'm Angie Urbina, your host for the dermatology series. Today, we're diving into a common yet potentially serious skin infection, cellulitis. We'll cover what it is, who's at risk, how to recognize it, and most importantly, how to manage it effectively in primary care. Let's get started. So, what is cellulitis? Cellulitis is a bacterial infection that involves the deeper dermis and subcutaneous tissue. It's usually caused by bacteria entering through a breach in the skin barrier, such as a cut, abrasion, or fungal infection. The most common pathogens are beta hemolytic streptococci, usually group A strep, and Staphylococcus aureus, including MRSA, which is methicillin-resistant Staph aureus in certain cases. Cellulitis can affect anyone, but some groups are at higher risk, such as older adults and those with weakened immune systems, like in diabetes and HIV, people with skin conditions like eczema or athlete's foot, injection drug users or those with surgical wounds, and individuals with lymphedema or venous insufficiency. Patients with cellulitis often present with an erythematous, edematous, tender, and warm, non-fluctuant plaque with poorly demarcated borders. Fever and chills may be present in more severe cases, and there is also possibility of lymphangitis, where streaks of redness extend toward regional lymph nodes. Cellulitis can occur anywhere, but the lower extremities are the most common site of presentation. The diagnosis of cellulitis is primarily clinical, but consider additional workup in certain cases, such as blood cultures, for example, if there's systemic signs of infection, or if treatment is not showing the results you are expecting. Also, in the case that the patient has purulent drainage, you may want to perform a wound culture. And as far as imaging, an ultrasound may help differentiate cellulitis from an abscess, or in the case that there is uncertainty about osteomyelitis, an MRI can be ordered. Now, let's talk about management. In non-purulent cellulitis, you want to treat empirically for beta hemolytic streptococci and methicillin-sensitive Staph aureus. Treatment options include antibiotics like cephalexin, amoxicillin, or dicloxacillin. Treatment will change when you need to add coverage for MRSA. This would be in cases such as patients with purulent cellulitis, when there is a known MRSA colonization or infection, history of injection drug use, immunocompromise, or signs of systemic toxicity such as fever or tachycardia. In these cases, antibiotic options would be trimethoprim sulfamethoxazole, which is Bactrim, doxycycline with amoxicillin, or linezolid. Lastly, it is important to understand when intravenous therapy is warranted. This would be in cases with rapidly progressive or extensive erythema, for patients with systemic toxicity, such as showing signs of fever or tachycardia, or inability to absorb oral therapy. An example of IV therapy includes vancomycin for MRSA coverage and cefazolin for methicillin-sensitive Staph aureus. Important additional measures are to elevate the affected area to reduce swelling and to address any portal of entry, such as treating athlete's foot or venous eczema. And in regard to prevention, preventative measures include good hygiene and prompt wound care, managing chronic conditions like diabetes, and educating patients about avoiding skin trauma as well as addressing fungal infections. You will want to watch for complications such as abscess formation, which may require incision and drainage. You also want to look for systemic symptoms like confusion or hypotension that would lead you to think of sepsis. And thirdly, always keep necrotizing fasciitis on your radar. This would present as a rapidly spreading and severely painful infection that is life-threatening and requires surgical debridement. Here are a few clinical pearls. Always check for portal of entry. Common sites include the toes, like in tinea pedis, legs, and surgical scars. Secondly, consider MRSA if cellulitis does not respond to antibiotics within 48 hours or if purulence is present. And lastly, keep in mind your differentials. Other rashes, such as venous stasis dermatitis or a contact dermatitis, can look like cellulitis and may lead to improper use of antibiotics. You will want to avoid this. Now, let's test ourselves with a couple of clinical questions. Question 1. A 45-year-old man presents with pain and redness to the left leg. Physical exam reveals a poorly demarcated erythematous and edematous plaque that is tender to palpation to the left lower leg. Physical exam also reveals scaling and erosions to multiple toes bilaterally. Patient has no past medical history other than tinea pedis. What is the most likely diagnosis? Is it A, necrotizing fasciitis, B, cellulitis, C, erysipelas, or D, venous stasis dermatitis? I'll give you a couple of seconds. If you chose B, cellulitis, you are correct. Cellulitis is the most likely diagnosis given the clinical presentation and predisposing factors like tinea pedis. Keep in mind that erysipelas presents similarly, but the borders are more raised and well demarcated. Question 2. A 50-year-old woman with diabetes mellitus type 2 presents with purulent cellulitis of the right leg. Vitals include a temperature of 100.8, pulse of 101, and blood pressure of 130/85. Which of the following is the treatment of choice? Is it A, cephalexin, B, trimethoprim sulfamethoxazole, which is Bactrim, C, amoxicillin, or D, azithromycin? If you chose C, Bactrim, you are correct. Bactrim is a great option since it provides MRSA and streptococcal coverage. MRSA coverage is warranted in this patient due to having purulent cellulitis, diabetes, and she also has systemic signs of fever and tachycardia. Awesome job. Thank you for listening to the Pro PA podcast. Don't forget to subscribe and turn on notifications so you never miss an episode. Be on the lookout for future episodes in our dermatology series to help you succeed in the clinic and ace the PANCE. And remember, this is the Pro PA podcast, where future pros in medicine are made. See you next time.